Well, thank you. So now we have a moment for an open discussion to hear your thoughts, your questions.
No, just a comment, if I can. Yes, thank you very much for these presentations. They are really, really very, very interesting, and it's impressive that some of the initiatives are similar to those we conducted in Italy, and also with those conducted during the joint action. And in particular, this last presentation is really has the same, I think, the same aim that the two joint actions, in particular CHRODIS PLUS, had. So to identify best practices, good practices, or best practices, as you want, and to share these experiences, because it's really important to share the successful initiative and to create this community for a better care for people with diabetes and chronic diseases. So it's really very interesting. I forgot to say that but I think that you know that in CHRODIS, the first joint action, we had also partners from Portugal. So the Association of Diabetic Patients, in particular with Rogério Ribeiro, and with Dr. Boavida of the General Directorate of Health.
Yes, and we invite them as stakeholders as well, and the idea of having this discussion of our plans and what will be the steps that we want to follow is really to have from your experience, your advice, so we can build on that experience as well.
I think that the most difficult point, it was a difficult point for us in CHRODIS, is to define when a practice is a good practice or a best practice. So the criteria for this definition. And we did a similar project, so defining the questionnaire, collecting the practices all around the European countries that collaborate with us. And the real problem was the definition of criteria, of course. That's why at the end we defined that set of quality criteria. But you know, it's not may not be a universal list of criteria. No, people can, of course, can change it, but it's the most important part is the definition of how to judge the practice.
I'm going to pick on that. What I expect is that we'll have several very good and practices. Romeu Mendes gave the example of the story of an excellent practice, impressive story, and we'll have that is very well documented, very well researched. It's really very well set up. It's really a model, so model for how to build, improve, and disseminate a practice. And of course, the aspects of sustainability or of expansion, it's on that level for that aspects. But we expect to have many small practice initiatives. I don't even make all not them practices, initiatives that don't have are very far from that maturity. We hope that this highlights, this project highlights also that, and that these practices may need help to be evaluated, to be valued, to be known actually, and so this aspect of identifying small initiatives, I think it will be maybe our greatest challenge. I would expect so. We have here a question from my friend Cristina Furtado. Hello, Cristina. If we are working together at national level or international. Well, this project that is implementing is a project at the national level, but we are very much inspired by the international projects, and so we had to evolve and to be supported by international experts, and that's that's our luck. Please feel free to write the questions on the chat or just open the mic. We did this presentation really to hear your thoughts and your experience, so that's very valuable to us. We really appreciate it.
So I have a question about diabetes in motion, a question to Romeu. You showed us where we are, and you have already told us that you want the future back and that you don't know what will happen in this future. But if we live in an ideal world, where should this project go?
Thank you, Nuno, for the question. Well, what we aimed when we accepted the project to be run by I'm not going to call it project anymore because it's a program with several community projects. Each project functions in seasons. This is public health technical stuff, sorry. I'm a public health geek. We would like to have a project from the Diabetes in Motion program on every municipality. That was our goal. Okay, not for every primary healthcare center, but Nuno, as you know, we organize the groups of patients on 30. So each primary healthcare medical doctor with his list of patients could feed a group of people of this community-based exercise program. But this is not a realistic objective. We just wanted to expand it to one project by municipality. What we have seen, although this is not collateral damage, like a secondary effect, we see many municipalities implementing our program, following our manual, but they don't want to call it Diabetes em Movimento, because sometimes municipalities, especially on elections year, they are very competitive and they don't want to assume that they want to implement someone else's idea. So they implement the same program because the program, all the details of the program, they are described on the scientific papers. And I personally, I'm happy with it. I have no problem with it. But I know that we have 32 municipalities and that we have maybe 30 municipalities more that they are implementing Diabetes em Movimento exercise dose and exercise structure with the same procedures for prevention of exercise injuries and adverse events, but they didn't contact us to implement the program. So maybe the future is going, maybe, I don't know, with COVID, to publish a manual like to publish a book, to publish a website with videos, maybe to do health literacy to municipalities and let them to implement what they want with the tools that we can give them to be available. Because we have a lot of issues when a municipality comes to us and they want to implement the program. We have a list, a checklist. Do you have a nurse full-time? Most of municipalities, they ask, why do you want a nurse on an exercise program? Why do we want a nurse? Who is measuring capillary blood glucose? Who is deciding if you are going to call 112 or 991? Who is watching the feet? Who is monitoring blood pressure? If you just have one exercise professional for 30 patients. And this is the function, this is the role of having a public health nurse or a family nurse on these programs. But internet has advantages and disadvantages, and almost more than 90% of municipalities that they are implementing the same exercise, but not calling it Diabetes em Movimento, they didn't hire a nurse. And this hurries me. I'm hurried about it. Because adverse events, you saw the table that I showed you, they happened. And when they happened, an exercise professional, even if it is very, very well trained, it is not a health professional. It is not trained to acutely manage an hypertensive crisis or an hypoglycemia or an hyperglycemia crisis.
Romeu, we have some questions in the Zoom chat, so I think if you can check, but we have a question about who should be contacted about the Diabetes em Movimento. Are you the person who gets the contact person?
Sometimes I am. Sometimes I do administrative work. I'm not complaining. I like to do it because it's, if you want to do it right, so do it yourself. That's my way. That's my way of life. Mm-hmm. The program, I just I read the question. On pre-COVID era, and I want my future back, as I said it before, on pre-COVID era, on every first trimester of the year, we open applications to Diabetes em Movimento. We open on, we have our own LinkedIn page, we have our own Facebook page. We sent an email to every health administrative regions, and they send emails to primary healthcare medical doctors, nurses, etc. So we have one opportunity to do applications to the program each year. Then we have a meeting, we assess the conditions, we expose what are the checklists, who wants to get in. It's voluntarily, it's not mandatory to apply to Diabetes em Movimento. So we expect to have people with a high motivation rate, and it's true. And magic happens. But we have a special period to open applications. I'm not sure if we are going to open applications on the first trimester of 2022. I'm not sure. For many reasons, Mm-hmm. Okay. One of the reasons is because the primary healthcare medical doctors and system, public health people, workers, field workers like me, we are full of work on vaccination, on screening, on testing, on schools, university. So we need to lower a little bit the effort that we are investing yet on COVID pandemic management. That is a high burden on primary health care, as most you know, as Nuno know that, and on public health professionals also. And this program is run by public health and primary healthcare professionals. Okay, but if everything goes well, we are going to open applications. You just need to be in contact with our Facebook every week or every month.
Okay, so I have a question. Using your experience with the Diabetes em Movimento as an example of good practice, what do you identify as the major barriers of the a dissemination of good practices. So in this initiative, we want to identify and then help disseminate good practices in diabetes. And what do you think will be the major issues, like looking to the future?
You want me to be honest? This is being recorded. So when things are in record, I'm not sure if I should be totally honest with you, but I'm going to be. I already explained the issue, that the main barrier is that institutions and organizations, I'm telling you this by my own experience, they don't like to replicate others' idea. They don't like to use others, people, brands, ideas, methods. Every organization wants to have their own brand, their own program, their own idea, their own concepts. And most of these ideas, they are not tested. Not for effectiveness, not for safety, not for acceptability, not even for efficacy, as Diabetes Movimento was. That you can think that this is a stupid issue, but for me, it's the major issue.
Okay, so maybe I'm just thinking here out loud. So probably you think that in general, like civil organizations or groups, they prefer like to adapt a practice that they know is a good practice. They think they are not doing harm by changing some aspects. They remove like the nurse, they remove something, and they don't care that doing that they will maybe missing the good practice as a whole. So what do you think are people see as a good thing of doing that? They think they are still doing a good practice. Do you think this is the motivation?
This is multifactorial and this is very complex, okay? One of the reasons is because when an institution, when they disseminate their own idea, they not always acknowledge where the idea was tested, okay? Like if it was like a drug, we call it, when we take a paracetamol, everyone knows that there is paracetamol and it was tested, safety, efficacy, etc., etc., etc. When you combine a community-based exercise program, you can implement it without any type of evaluation. Okay, so there are some municipalities or institutions. I don't want to be unfair. I'm not talking only about municipalities. I know primary healthcare centers that they are implementing similar projects on their primary healthcare. I know hospitals that are doing the same thing. I know universities, and I know also municipalities. Okay, but mostly it's true. They are municipalities. They are doing it. From my best knowledge, they are not technically implementing the original idea. They are doing changes, and these changes compromise the clinical effectiveness of the program, and most serious, they compromise the safety of the participants. When I was young, I thought that people would like packages ready to eat, but now I'm on the 40s, I don't believe that anymore. Okay, when it comes to implement community programs, people don't like to eat the other's idea. Sorry for the informal language. So Elisa, for me, we must do health literacy to organizations, not to give them, oh, this is the package, this is my package, take it, implemented it. People don't like to implement others. I'm repeating myself, I know, but this is the idea. Okay, we should give them the tools instead of saying them it's for Diabetes in Movimento, it's mandatory to have a nurse. We should say first, diabetes has some comorbidities. Comorbidities can have serious adverse events must be clinically and acutely, like an emergency. They have to be managed, and you need a health professional to manage acute adverse events. This is why we need a nurse.
And do you think that outside community interventions, other practices, policies in diabetes will face similar issues, or this is something more like something more specific to community intervention? So if we are dealing with other good practices, we will not face the same issues.
Lisa, I think it depends on the institution. Health institutions, even on pre-COVID, we don't have the resources to implement community-based programs. We don't have it. I'm talking for I can talk about for the public health task force. We don't have enough resources. We have enough. We have other important things to do that are top-down. We have the programs of the Director General of Health, vaccination, child's health, maternity health, screening, cancer screening, diabetes, hypertension, etc., etc., etc. So we must have highly motivated health professionals to implement programs that are out of the box. So, to the best of my knowledge, these programs are implemented by non-health professionals organizations. And these institutions that are not based on health, they don't know enough of diabetes or the chronic disease or the health outcome that you want to attain. They don't know enough of the problem in order to implement a safe and wholesome community program. So they need to be literated. They need literacy for the disease or the problem that we want to approach. Okay. This is very complex. Okay.
Mm-hmm. So
I'm sorry.
Okay, sorry.
I'm sorry, I'm not sure if I can have a question to Romeu. My name is Cristina Furtado. I work at National Institute of Health and also in the Faculty of Medicine. But I'm asking you, I'm quite interested in your work, and it was really a pleasure to hear you. So, are you thinking to contact the local pharmacies? I'm a pharmacist, so I think they are, of course, from the primary cares, and they are the first line sometimes of many disease and many supports and alerts. So have you done that, to contact the pharmacies and to have the support of them, to contact and so on and so on? It's quite interesting. Probably it will help. I have no idea. I'm sorry. Thank you very much. And thank you to all. It was very interesting.
Thank you, Cristina.
I'm sorry, because for me, it's really a new thing. I'm from infection disease. So, but it's really interesting. Thank you to all. Thank you.
Thank you for the question. I'm laughing because I have a PhD student in pharmacy. His name is Ruben Viegas, and I'm the co-supervisor. The supervisor is Felipe Alves da Costa, that is now working with me on World Health Organization. So we are going to test the role of the community pharmacy in promoting physical activity with patients with type 2 diabetes. So we thought about it, and we want to implement a randomized controlled trial to test it.
Yeah, it's quite interesting. Good. Congratulations. Good.
Because pharmacists, they do health advices. They know about health. They are health professionals. If they do counseling on smoking cessation or on alcohol or on nutrition, they cannot. Why they cannot counseling someone on physical activity? They can do it. They just need to be trained for it.
They are in first line.
I know that. I know.
You know that. Thank you.
But they are health professionals. Okay. What worries me most, and finishing, sorry, Elisa, for speaking so much. What worries me most is institutions that they don't have health professionals. They really are motivating to work with health outcomes, but sometimes they don't know what they are doing. I'm talking by personal experience, okay? Both from Diabetes em Movimento, but also from the other side of implementing a walking football program and to working closely with football clubs and also with municipalities. We need to work more closely on a multidisciplinary way. Sorry, Lisa.
Dr. Nuno, I have one question for Marina. Can I have that question? Thank you.
Yes.
So my question is, Marina, what are your thoughts about the implementation? So with the CHRODIS and CHRODIS Plus, you end up having the platform, the portal, so people can submit their good practice there. You have the criteria to judge. So you did all that work during those two projects. So do you think there's what will be like the next steps of CHRODIS Plus? What is missing? Do you think there's something missing, or it was enough on doing that, by doing that?
Oh, I think that it's enough, but of course, now the future is how to use all the results that CHRODIS has obtained. The first CHRODIS defined a platform, and we use this platform defining, of course, the criteria for defining best practice and so on. But the platform was not continued in CHRODIS Plus, and in CHRODIS, the Commission, the European Commission, decided to implement a new platform for collecting good practices. So, you know, also in this big European project, sometimes some of the results that you obtain in one project doesn't really remain in the subsequent work. What we expect is that, in particular for our work package, of course, I don't want to give also result of other work packages, but in particular for our work package, we hope that both the QCR, the quality criteria recommendations, and the guide to implement good practices, we really hope that tools can be used. I think also Jelka, my Slovenian colleagues, I think that they may be really useful for professionals, patients, policymakers, and so on.
Okay, so we have reached our limit, our time, and I think that this was a very useful meeting for all of us. We talk about sustainable practice based on quality criteria recommendations. We approach the importance of lifestyle intervention in the treatment of diabetes and the value of community-based exercise programs and interventions. And finally, we have discussed how to maximize the dissemination and impact of best practices. These are all important points related to diabetes, and we will certainly have other opportunities in the future to discuss these and other issues. Once again, I would like to thank everyone who attended this meeting, especially our speakers, and a special thanks to the Institute for Evidence-Based Healthcare for organizing this meeting. So I hope to see you soon, and see you next time.